Hello, everyone.
Hello.
Yeah.
Hello,
Yeah.
everyone.
How
Uh,
it was how it was muted. Anyway, please carry on.
okay. Hello, ladies and gentlemen. Welcome to the webinar on Yes, We Can End TB on World Tuberculosis Day. I'm Himanshu Saxena, and I'm honored to serve as the moderator for this event today. Before we dive into our discussion on TB prevention and control, I would like to take a moment to introduce you to my company, Techsci Research. Techsci Research is a leading market research and consulting firm with offices in US, UK, and India that provides market research reports in a number of areas to organizations: healthcare, chemical, agriculture, automotive, consumer, infrastructure are some of the key verticals in which Techsci Research offers market research and advisory solutions to its customer worldwide. Today, on the World Tuberculosis Day, we have come together to remind the world of the enduring global health crisis that tuberculosis continues to be. With millions of people suffering from TB each year, it is vital that we continue to prioritize prevention, diagnosis, and treatment. Over the course of the webinar, Over the course of the webinar, I will bring together experts and stakeholders to discuss innovative solutions that can help achieve the end of the TB of 2025. Again, as a moderator, I am honored to be working alongside some of the brightest minds in the field of global health. The speakers we have lined up today are at the forefront of TB prevention and care and will share their experience and insights into the most pressing issues in the fight against TB. Through the discussion and the presentation, we aim to raise awareness about the challenges of tuberculosis prevention and control and find new ways to encourage investment in TB prevention and care. Thank you all for taking the time to join us, and let's start with our first speaker for the day. Our first speaker is Mr. Abhinav Singh. He is directly associated with National Tuberculosis Elimination Program, which is NTEP, and doing the groundwork for the implementation and elimination of TB. Currently, he is the enacting senior treatment supervisor for National Health Bill. Hello, Abhinav.
Thank you, Himanshu. Thank
Yeah.
you, Shaurya, for having me here. Uh, am I audible?
Yes.
Okay. Himanshu, can you just go on the previous slide? The definition of the TB.
Sure.
Yeah. Today we are celebrating World Tuberculosis Day, and yes, we can end TB. Uh, TB. I would like to speak in Hindi for the better connection with the audience. हम टीबी के बारे में हम क्या जानते हैं? दरअसल टीबी एक ऐसी बीमारी है जो कि एक बैक्टीरिया से होती है, जिसे हम कहते हैं माइक्रोबैक्टीरियम ट्यूबरकुलोसिस। अब टीबी इन्फेक्शन जो होता है, जो भी बैक्टीरिया होते हैं, ये हमारे लंग्स में डायरेक्टली इम्पैक्ट करते हैं। और टीबी एक ऐसी बैक्टीरिया है जो कि डायरेक्टली लंग्स में ना जाके ये बॉडी के कहीं किसी पार्ट्स में हो सकती है। जस्ट लाइक नेल, एक्सेप्ट नेल एंड हेयर्स, टीबी किसी भी बॉडी पार्ट में आपके हो सकती है। और इसके लिए हम पहले चेक करते हैं टीबी की होती कैसे। टीबी किसे पता चले हुआ किसे टीबी? टीबी हम दो कैटेगरीज में डिवाइड करते हैं टीबी को। एक होता है लेटेंट टीबी इन्फेक्शन, एक होता है टीबी इन्फेक्शन। लेटेंट टीबी इन्फेक्शन इज दैट लाइक आपके अंदर बैक्टीरिया है बट वो इनएक्टिव फॉर्म में है। आपके अंदर कोई सिम्टम्स नहीं आएंगे, आपका इम्यून पावर अच्छा है, आपके अंदर कोई सिम्टम्स नहीं आएंगे और आप किसी को बैक्टीरिया फैला नहीं सकते हो क्योंकि ये इनएक्टिव फॉर्म में है। आपका चेस्ट एक्सरे बिल्कुल नॉर्मल होगा, स्पुटम स्मेयर जो होता है वो नेगेटिव होगा, सब कुछ होगा। बट आप ये टेस्ट कर सकते हो थ्रू योर स्किन टेस्ट और ब्लड टेस्ट कि आपके अंदर ये है, ट्यूबरकुलोसिस है। In the case of TB infection, symptoms are like, can you go on the next slide?
Yeah.
Yeah, here we have the TB infectious symptoms. The cough is more than 2 weeks. You have fever, continuous fever, loss in appetite, or you having a weight loss, a chest pain. These are the symptoms of the tuberculosis. If you're having any of these symptoms, you can go to your nearest CSC, that is Community Health Center. You can have their free of cost your sputum test, and you can get results somewhere there कि आपको टीबी है कि नहीं. ठीक है, तो आप नजदीकी अपने सीएससी पे जाइए अगर आपको सिम्टम्स आ रहे हैं, और आप अपनी जांच कराइए, अपने बलगम की जांच कराइए. आपको वहाँ पे रिजल्ट्स आपको तुरंत मिलेंगे कि आपको टीबी है कि नहीं है. और हम इसके बारे में आगे बात करते हैं, इसकी डायग्नोज कैसे करते हैं हम इस टीबी को अपने उस पे सीएससी पे. अब डायग्नोज टीबी की होती है, जैसे हमने बात किया लेटेंट टीबी की, तो लेटेंट टीबी जो होता है हमारा, ये ब्लड टेस्ट स्किन टेस्ट से होता है. बट हम ये नहीं कह सकते कि एक्टिव फॉर्म में लेटेंट टीबी में ब्लड और स्किन टेस्ट से हम नहीं कह सकते कि एक्टिव है या इनएक्टिव है. बस हमें ये पता चलेगा कि हमारे अंदर ट्यूबरकुलोसिस के बैक्टीरिया है. लेकिन अगर हम स्पुटम टेस्ट कराते हैं, अगर आपका ब्लड टेस्ट स्किन टेस्ट में पॉजिटिव आ रहा है, तो आप स्पुटम एक टेस्ट कराइए आप अपना, तो आप उसको पता चलता है उसमें कि हमें क्या है, मतलब ट्यूबरकुलोसिस है या नहीं है. बेसिकली ज्यादातर हमें पल्मोनरी केसेस दिखते हैं, क्योंकि ये वाइडली स्प्रेड होते हैं. जैसे हम खांसते या छींकते हैं, जस्ट लाइक कोरोना वायरस, हम कम्युनिकेट करते हैं, दिस इज कम्युनिकेबल डिजीज. अदर देन पल्मोनरी के अलावा ये ट्यूबरकुलोसिस बाकी जो होते हैं हमारे एक्स्ट्रा पल्मोनरी में आते हैं, जो कि आपके स्पाइन, ब्रेन या कहीं पे भी हो सकते हैं. स्पाइन हो गया, ब्रेन हो गया, बोन हो गया, एनीवेयर कहीं भी हो सकते हैं. बट इसके केसेस हमें कम देखने को मिलते हैं, क्योंकि ये बहुत ही रेयरली होते हैं कि आपके लंग्स से ये किसी और बॉडी पार्ट में जाएं. ज्यादातर केसेस हमें पल्मोनरी के दिखते हैं, तो उसके लिए हमें स्पुटम टेस्ट कराना होता है, और हम इसे कर सकते हैं. और बाकी सिम्टम्स एपीटीबी के लिए, जस्ट लाइक वी हैव ब्रेन टीबी, वी कैन गो फॉर एफनैक टेस्टिंग. एंड who should be tested for the TB? Here we can see that people who are migrated from the countries where TB is very high, they can go for the testings for sure, that there is high chances they can have TB. Patients having a HIV positive cases are like they don't have the proper immune system. Their immune system are so weak they can easily get TB. And in our case, 40% TB are HIV positive, and they can have. And people who are sick and they don't have immunity system, just like after COVID, many people have TB, tuberculosis, because their immune system was so weak. And kids, especially kids, we have below the age of 5 years, they are highly at risk of the tuberculosis, because of they get their immune system was so weak, they are under the vaccination process, though, so their vaccination doses are not complete till then. They can have tuberculosis. And the people are working in the close community, just like mines. They are working in a mine, where in a close environment they work in a huge crowded area. They can have TB testings. Now, if we talk about the treatments here, TB positive patient we can categorize them into two parts. That is preventive TB preventive therapy. With that, we give here. Currently, we are giving to the children below the 5 year. We give them isoniazide tablets. But we are planning. Government is planning to get TB preventive therapy start for adults also. We are under we will soon start also that we will give them rifampicin for that. With these patients, if किसी के अगर फैमिली में अगर कोई पॉजिटिव पेशेंट है, और उसके घर में छोटे बच्चे हैं, 6 साल से छोटे हैं या 5 साल से छोटे हैं, तो उसे हम आइसोजेनाइज के टैबलेट्स देते हैं, ताकि उसको ट्यूबरकुलोसिस से प्रिवेंशन दिया जा सके, क्योंकि उनके हाई रिस्क होता है ये. अभी हम एडल्ट्स के इनिशियल फेज में हैं यहाँ पे, कि एडल्ट्स की भी हम रिफापेंटिन शुरू करेंगे, ताकि जहाँ पे वो अपने प्रिवेंशन कर सकते हैं टीबी ट्यूबरकुलोसिस पेशेंट के साथ में. अब ये टीबी डिजीज जो इन्फेक्टेड पर्सन है, उसकी भी हम ट्रीटमेंट दो कैटेगरी में डिवाइड करते हैं. दैट इज डीएसटीबी एंड डीआरटीबी, ड्रग ससेप्टेबल टीबी एंड ड्रग रेजिस्टेंट टीबी. ड्रग ससेप्टेबल टीबी आर कोर्स ऑफ 6 months. that is dots. Through dots, we give them treatment. And if a patient go through the DSTB treatment, अगर वो 6 महीने प्रॉपरली दवा खाता है तो हम उसकी टीबी की बीमारी को खत्म कर सकते हैं इजिली। बट पेशेंट्स के चैलेंज ये होते हैं कि वो दवा को बीच बीच में छोड़ते रहते हैं। अगर उन्हें थोड़ी सी आराम मिल जाता है वो छोड़ देते हैं पेशेंट दवा को। हमें ज़्यादातर देखने को मिलता है कि भी जो हमारे मतलब अनएजुकेटेड पीपल हैं वो हमारे या ड्रग्स को छोड़ देते हैं। वो सोचते हैं कि अभी तो आराम मिल गया। हमारे पास पेशेंट्स आते हैं बट वो कहते हैं कि अगर हमें आराम मिल जाता है 1 महीने में तो अगर हम छोड़ दें तो कोई दिक्कत है, क्योंकि उनको ड्रग्स से साइड इफेक्ट्स भी दिखते हैं। उनके चेस्ट में पेन होता है, उनको जलन महसूस होती है, उनको नोजिया होता है, वॉमिटिंग होती है। तो इस वजह से वो सोचते हैं कि हम दवा छोड़ देते हैं, अभी तो हमें आराम मिल गया है। बट इससे क्या होता है कि वो ड्रग के लिए रेजिस्टेंट हो जाते हैं। और प्रॉब्लम ये होती है, ड्रग रेजिस्टेंट टीबी को हम 2 कैटेगरी में डिवाइड करते हैं, एमडीआर एंड एक्सडीआर। अब एमडीआर पेशेंट्स आर rifamycin resistant, that is shorter regimen, and the XDR is a longer regimen. And SCR patient this इनके बचने के चांसेस भी थोड़े हाई रिस्क के होते हैं, इनके बचने के चांसेस भी थोड़े कम होते हैं। बट वी कैन ट्रीट देम इफ दे टेक प्रॉपरली, बट द ट्रीटमेंट विल बी लॉन्गर। एंड पेशेंट के लिए ये पॉसिबल नहीं होता है, क्योंकि वो 6 महीने जब दवा नहीं करता है तो लंबे प्रोसेस के लिए दवा भी नहीं कर पाता है, और इसके उसमें वो ड्रग्स छोड़ देता है। अब पेशेंट अपना इलाज प्रॉपरली करता रहे, इसके लिए हम फैसिलिटीज भी बहुत सारी देते हैं उनको, ताकि उनका वो हो सके। जैसे आप स्लाइड में देख सकते हैं, पहला हम मेडिकेशन देते हैं उनको। मेडिकेशन उनको यहाँ पे फ्री ऑफ कॉस्ट में मिलता है। सीएससी लेवल पे आपको कहीं पे भी, आप सीएससी या पीएससी लेवल पे जहाँ पे टीबी यूनिट्स बनी हुई हैं, वहाँ पे आपको मेडिकेशंस प्रॉपरली मिल जाएंगे, फ्री ऑफ कॉस्ट मिलेंगे। और हमारी आशा जो है वो हमारी ट्रीटमेंट सपोर्टर है इसमें, लाइक विलेज लेवल और अर्बन लेवल। आशा इज ए डॉट्स ट्रीटमेंट सपोर्टर, ऑल्सो डॉट्स प्रोवाइडर। तो आशा हमारे सीएससी या पीएससी से दवाइयाँ लेके जाती हैं, और वो डायरेक्टली उनके सामने, आशा के सामने ही वो पेशेंट दवा खाता है, और हमें इसे श्योरिटी मिलती है कि पेशेंट दवा खा रहा है। और इसके लिए हम ट्रीटमेंट सपोर्टर को कुछ इंसेंटिव, कुछ ऑनरेडियम भी देते हैं यहाँ पे। और दूसरी चीज है निक्षय पोषण योजना। तो पीपल आर पुअर फ्रॉम पुअर बैकग्राउंड, जो कि गरीब लोग हैं, जिनके पास प्रॉपरली दवा के लिए या प्रॉपर न्यूट्रिशन के लिए पैसे नहीं हैं, या किसी भी चीज़ की उनको प्रॉब्लम हो रही न्यूट्रिशन सपोर्ट में के लिए, इसके लिए। और हमारे प्रधानमंत्री जी ने 500 रुपीज पर मंथ के लिए हमारे इंसेंटिव दिया है। तो जब तक ये ट्रीटमेंट चलेगा तब तक मरीज को 500 रुपये हर महीने उसके न्यूट्रिशनल सपोर्ट के लिए मिलता रहेगा। अपार्ट फ्रॉम दैट, फ्रॉम 2022 our president also started community support, that is निक्षय मित्र। हमारे इस कम्युनिटी में जो भी लोग हैं, जो भी निक्षय मित्र बनना चाहता है, कोई भी हो, एनीबॉडी, कोई भी पॉलिटिकल पार्टी से हो, इंडिविजुअल हो, एनजीओ हो, डॉक्टर हो, वर्किंग प्रोफेशनल हो, कोई भी हो, वो आके निक्षय मित्र बन सकता है, जिसमें उसको न्यूट्रिशनल सपोर्ट, वोकेशनल सपोर्ट आपके लिए दे सकता है वो वहाँ पे आके पेशेंट को, ताकि वो अपनी बीमारी को अच्छे तरीके से ट्रीट कर सके। और other initiative taken by the governments are 99 dots. We are working on 99 dots. That is, it's an envelope that if a patient has a dose of 3 tablets, just like he has a dose of 3 tablets, after that he opens that envelope, he will open or she will open. There is a toll-free number behind that. We register patient through his or her mobile number. He just call that number, and the our system will directly through the AI that patient has taken the pill, and here we can say the treatment supporter on radium. The हमारी आशा को हम 1000 रुपये ट्रीटमेंट कंप्लीट होने पे देते हैं फॉर डॉट्स प्रोवाइडर। एंड इन्फॉर्मेंट इंसेंटिव्स आर ऑल्सो देयर कि हमें टीबी केसेस नहीं मिल रहे हैं, तो उसके लिए हमने क्या किया है, अगर आपकी कम्युनिटी में कोई भी मरीज है जिसको सस्पेक्टेड टीबी आप लगता है, आपको सस्पेक्ट करते हैं कि उसको टीबी हो सकती है, आप उसको काउंसिल करके आप सीएससी पे ले आइए। CSC पे ले आइए, उसकी टेस्टिंग कराइए। अगर वो पॉजिटिव आता है तो हमें इन्फॉर्मेंट के सपोर्ट, सब इन्फॉर्मेंट के लिए हमने 500 रुपीज पर पॉजिटिव केस पे हमने इंसेंटिव रखा है कि इन्फॉर्मेंट को 500 रुपये हम देंगे। अपार्ट फ्रॉम दैट, ऑन निक्षय दिवस पे हम हमारे प्रधानमंत्री मुख्यमंत्री जी हैं, माननीय योगी आदित्यनाथ जी ने, उन्होंने शुरू किया है निक्षय दिवस। On every 15th of every month, we celebrate Nikshay Divas. We celebrate Nikshay Divas. We celebrate Nikshay Divas, in which generally we take 5% of OPD, but on Nikshay Divas we take 10% of OPD referral for the Nikshay testing, and here we see the challenges in TB elimination. There are many challenges in TB elimination. The first challenge is the stigma. There is stigma in community. हमारे समाज में एक स्टिग्मा है कि कोई भी पेशेंट अगर है टीबी पॉजिटिव तो उसको अछूत की नज़र से देखते हैं हमें हमारे समाज में, कि अगर उसको टीबी है तो उससे दूर रहो। और उसके इससे क्या होता है कि उसके अंदर एक साइकोलॉजिकल, एक सोशल एक्सेप्टेंस नहीं हो पाती है ट्यूबरक्लोसिस पेशेंट के अंदर, कि अब हमें टीबी हो गया। तो जनरली क्या होता है, हमारे पास पेशेंट आते हैं ओल्ड एज के, तो अगर उनको टीबी हो गया है तो उनके जो फैमिली है तो उनको बाहर कर देती है उनके घर से, और ये उनके लिए एक चैलेंज होता है, और हमारे लिए भी चैलेंज होता है कि उनका ट्रीटमेंट प्रॉपर्ली हो, उनकी केयर प्रॉपर्ली, उनका न्यूट्रिशनल सपोर्ट प्रॉपर्ली मिले। और दूसरा चैलेंज हम जो देखते हैं वो ये है कि ट्रस्ट बिटवीन द पब्लिक और गवर्नमेंट के बीच में, हेल्थ फैसिलिटीज में ट्रस्ट जो होता है, पब्लिक जनरली ट्रस्ट नहीं करती है गवर्नमेंट फैसिलिटीज पे, बट वी आर जो फैसिलिटीज हम प्राइवेट लेवल पे दे रहे हैं वही फैसिलिटीज हम गवर्नमेंट लेवल पे भी दे रहे हैं। सारी फैसिलिटीज अवेलेबल हैं, हमें ये बिल्ड करना है बस कि गवर्नमेंट फैसिलिटीज आर आल्सो कैपेबल एज इक्वल टू द प्राइवेट फैसिलिटीज। And there is another challenge in private health sector also, that unregulated health facilities. We have many hospitals and clinics that are unregulated, unregistered doctors, unregistered professionals who are treating TB. More than they are treating TB, they are making drug-resistant TB. Patient go there and just take a normal medication for their cough or chest pain, or if they start that treatment of the tuberculosis, they don't give follow-ups by visiting their home or by calling them. On government sector, we call the patient every month. We go for the follow-ups, whether they are taking pills or not taking pills. Unregulated health facilities are big challenge for the government to end TB. And another thing is hygiene. If we don't have the good hygiene, there are possible more chances to get TB. And lack of education is there. Lack of education is linked to the stigma. If you don't have proper education about the TB, then हमारे पास स्टिग्मा ये जरूर होगा कि ये टीबी है, इनको तो इनसे दूर रहना है। हमारे पास HIV केसेस भी आते हैं जो कि लिंक्ड होते हैं ट्यूबरक्लोसिस से। जस्ट लाइक मदर के पास ट्यूबरक्लोसिस था, मैं एक केस की बात करता हूँ, तो उसके फैमिली आती है कि हमारे घर में मदर की डेथ होती है ट्यूबरक्लोसिस से, एंड शी वाज HIV पॉजिटिव। एंड उसका एक बेटा था जिसके पास में वो भी HIV पॉजिटिव है, बट वो ट्यूबरक्लोसिस अभी निगेटिव है। बट उनका कंसर्न ये था कि अगर इसको हम फैमिली में रखेंगे तो हमें HIV हो जाएगा और हमें ट्यूबरक्लोसिस भी हो जाएगा। तो हमने उनको ये काउंसल किया कि इससे कुछ नहीं होगा, HIV के हमने सारे सिम्टम्स, HIV ऐसे नहीं फैलता है। उनके पास प्रॉपरली एजुकेशन नहीं था, हेल्थ एजुकेशन नहीं थी, जिससे वो HIV या TB के बारे में ज़्यादा कुछ जान सके। हमारा अगला वो जो चैलेंज है ये है मेडिसिन अवेलेबिलिटी। मेडिसिन अवेलेबिलिटी ऐसी है कि हमारे पास प्रॉपरली ऑन टाइम कभी कभी होता है कि हमारे पास मेडिसिन अवेलेबिलिटी जो होती है कि लेस होती है, क्योंकि हाई नंबर ऑफ पेशेंट होते हैं, और ट्रांसपोर्टेशन की वजह से हमारे पास मेडिसिन अवेलेबिलिटी रेयरली होता है, बट ये थोड़ा स्मॉल चैलेंज है, बट चैलेंज है ये भी कि मेडिसिन हमारे पास पहुंचते टाइम पे, लास्ट मोमेंट पे मेडिसिन पहुंच ही जाती हैं। ऐसा तो नहीं हो रहा है कि पहुंचती हैं, बट पहुंच जाती हैं। बट ये चैलेंज रहता है कि मेडिसिन पहुंच पाएगी या नहीं पहुंच पाएगी। हमारे पास सोल्यूशन ये है इस चीज़ के लिए, कैंपेन्स इसके लिए, कि हमें ज़्यादा से ज़्यादा अवेयरनेस फैलानी है, फैमिली थ्रू काउंसलिंग, थ्रू नुक्कड़ नाटक और एनीथिंग दैट कैन बेटर कम्युनिकेशन विद द पब्लिक, कि टीबी एक टीबी से हमें स्टिग्मा दूर करना कि क्योरेबल नहीं है। इन्वॉल्वमेंट ऑफ द लीडर्स, जैसे हमारे जो कम्युनिटी लीडर्स हैं या रिलीजियस लीडर्स हैं, इनकी लोग बातें ज़्यादा सुनते हैं। तो हमें मोर इनकी ज़्यादा सुनते हैं, तो हमें इनको काउंसल करना है कि ये कम्युनिटी में अगर जाते हैं तो इस चीज़ को लेके बातें लोगों को बताएं कि ये क्योरेबल है, कोई इसमें दिक्कत नहीं आती है। और हमें पब्लिक प्राइवेट मिक्स पार्टनरशिप करनी पड़ेगी, जो कि हम कर रहे हैं करेंटली स्टेज में। और हमें प्राइवेट सेक्टर से जो भी वो होते हैं, जो भी इन्रोलमेंट होते हैं, वो हमारे पास आते हैं यहाँ पे, नोटिफाई करना पड़ता है उन्हें। बट somehow some public some private sectors are not notifying them to our CSC. Next thing is that about wash is very necessary. बेसिकली हमें स्कूल में से स्कूल टाइम से ये सेशन हमें शुरू कर देने चाहिए कि स्कूल एंड कॉलेजेस से, कि वॉश की इंपॉर्टेंस क्या है, हेल्थ की इंपॉर्टेंस क्या है। प्रॉपर वॉश के लिए हमें पास उनके सेशंस लेने चाहिए स्कूल में जाके, ताकि वो, अगर उनके पास गुड हाइजीन होगी, अच्छी हाइजीन होगी, तो वो बीमारियों से ज़्यादातर दूर रहेंगे। हमें प्रॉपरली फॉलो अप करना पड़ेगा पेशेंट्स का, कि हम बार बार उनके घर पे जाएं या ऑन कॉल उनका फॉलो अप करें, वो दवाई खा रहे हैं नहीं खा रहे हैं, उनका कैसा चल रहा है ट्रीटमेंट, उनको कोई एडवर्स इवेंट्स तो नहीं आ रहे हैं ट्यूबरक्लोसिस के दौरान में। और अगला चैलेंज ये सोल्यूशन ये है कि मेल नरिशमेंट से फाइट करने के लिए हमें, जैसे कि हमने निक्षय मित्र शुरू किए हैं मेल नरिशमेंट के लिए, प्रॉपर हेल्दी डाइट बहुत ज़रूरी है। जो कि हमारे ड्रग एडिक्टेड जो लोग होते हैं, वो प्रॉपर उनका न्यूट्रिशन नहीं होता है। और हमारे बच्चे जो है काफ़ी पुअर बैकग्राउंड से जो होते हैं, उनकी नरिशमेंट अच्छी नहीं हो पाती, तो उनके बहुत हाई चांस होते हैं। उनके नरिशमेंट के लिए हमें बहुत ध्यान देना होगा, जैसे आंगनबाड़ी केंद्र हमारे हैं या मिड डे मील योजना चलती है, उनमें प्रॉपर न्यूट्रिशन उनको दिया जाए, उनके एजुकेशन उनके टाइम पे। और स्टार्ट टेकिंग द प्राइवेट health facilities that are unregulated, we have to take action against them, so that the patient can directly approach the CSC. And yes, we can end TB by 2025. India can end TB by 2025. Thank you.
Okay. So, sir, we also have some interesting questions for you. Again, you shed really important insights on TB and on your personal experience while dealing with
Okay.
the patients and your personal stories. So, we have few questions for you from our audience. I'll flash it for you.
Okay.
So, uh, again, can TB be eradicated at an earlier stage if diagnosed?
At earlier, but हमें 6 महीने की कोर्स उसके लिए करनी पड़ेंगे। इफ यू आर टीबी पॉजिटिव, बट टीबी पॉजिटिव अगर आप हैं, तो हमें 6 मंथ्स के उसके लिए हमें कोर्स उसका पूरा करना पड़ेगा। बट ये रहता अश्योरिटी रहती है कि अगर अर्ली स्टेज पे ट्यूबरक्लोसिस डिटेक्ट हो जा रही है, तो हम उसे 6 महीने में क्योर कर सकते हैं।
Okay. Then any other question that we have from our viewer is what are the main symptoms of TB and coughing after COVID? Is it normal or is there a difference between the normal coughing and the tuberculosis? And how we differentiate between the two?
The the symptoms of TB are, if you are having a fever, continuous fever from weeks, और कफिंग आपकी लगातार आ रही है, 2 हफ्ते से ज़्यादा हो चुके हैं कफिंग को। और कफिंग, नॉर्मल कफिंग जो होती है हमारी, उसमें ब्लड नहीं आता है, बट ट्यूबरक्लोसिस में कभी कभी हमारे पास ब्लड आता है। हम उसको डिफ्रेंशिएट नहीं कर सकते नॉर्मल कफ में और ट्यूबरक्लोसिस कफिंग में। बट अगर आपके कफ जो है वो मोर देन 2 वीक्स है, तो आपको एक बार स्पुटम टेस्ट करा लेना चाहिए आपके नियरेस्ट हेल्थ सेंटर पे।
Okay. And like you earlier mentioned, the incubation period for TB in this case also will be of 6 months, right?
या यस।
Okay. Again, another question from our viewer is ki why is it hard to diagnose tuberculosis and is it contagious?
Actually, in tuberculosis, if अगर हम स्पुटम की टेस्ट करते हैं तो बेसिकली हमें स्पुटम चाहिए होता है कंटेनर में, स्पुटम में हमें करंट चाहिए होता है, बट पेशेंट को कभी कभी कफ नहीं आता होता जब वो सैंपल देता है, तो
Hmm.
कफ की बजाय वहाँ पे हमें सलाइवा मिलता है। तो सलाइवा पे हम डिटेक्ट नहीं कर सकते कि ट्यूबरक्लोसिस है या नहीं है। तो ज़्यादातर चांसेस यही होते हैं कि हम खाली पेट जो होता है, हमारा कफ जो होता है
Hmm.
वो परफेक्ट होता है कि हम उसे ट्यूबरक्लोसिस टेस्ट कर सकते हैं, क्योंकि हमारे जो दिन भर हम कुछ ना कुछ खाते रहते हैं तो कि हमारे गले में कहीं ना कहीं लगा होता है। तो
Right.
खाने के साथ में सैंपल की इम्प्योरिटीज बढ़ जाती हैं, तो हम खाली पेट कफ अगर कराते हैं और वो सलाइवा ना होके कफ अगर रहेगा तो डिटेक्ट हो सकता है, बट मोर चांसेस ये होते हैं कि हम सलाइवा दे के आते हैं कफ की जगह पे, तो डिटेक्ट ये नहीं हो पाता है।
Okay. Another question that we have from you, from viewers, is key again, when compared with normal people, is there a particular section of the society or people who are more prone to the TB disease?
Yes, the weaker and the vulnerable section are more having TB in my in my field here. In my field, I'm here in the Azamgarh district. People working at just like labor class working, they have poor hygiene and they are drug addicted. They have HIV. There are many things. They have weak immune system. They have more TB than the normal people or people from the higher classes.
Okay. So, and like you mentioned about the different methods for identifying TB, ki whether a person is having TB or not, is there a better method, fastest method to diagnose TB?
There's the fastest method. We cannot say anything that is fastest method to diagnose TB. But if you have positive testing for the TB, you must go for the UDST, that is drug susceptibility test, that is done through the CB naught machine. And in that case, we test for the whether TB patient is drug resistant or not.
Okay.
There is
Uh,
no fast.
Okay, sir. And we have one more question for you that children below the age of 1 year can be affected by the TB. Is there chances for tuberculosis infection in them?
Yeah, that is very possible. They can have TB because the BCG vaccine is the key. If you have BCG vaccine, that prevent from the tuberculosis. But after the BCG can fail. For that, we have the TPT. We give them isoniazid uh, with their weight band for the prevention of the TB tuberculosis therapy.
Okay, sir. So that's all for you, sir. Let's move to Kamlesh, sir. So another esteemed speaker for our event is Dr. Kamlesh Sarkar, sir. He's a public health physician by training, retired as director ICMR National Institute of Occupational Health, Ahmedabad. He has more than 33 years of rich experience and has successfully completed a number of community-based public health projects on HIV, AIDS, malaria, TB, malnutrition, diabetes, hypertension, silicosis, lead poisoning, among others. He has also published more than 80 original articles on various reputed national and international journals, and he is the recipient of the prestigious ICMR Award, Dr. M.K. Sheshadri Prize, for his distinguished contribution to the field of HIV/AIDS in the year 2020, in the year 2006. Hello, sir.
Yeah. At the outset, I must thank. Am I audible?
Yes, sir. We all can hear you, sir.
Okay. Okay. At the outset, I must thank the organizers for inviting me and giving me opportunity for this presentation. So my topic is basically it was shown in the screen. Without control of silicosis, TB elimination is not possible. That is based on our experience. We have realized this. That we want to share why we are talking like this. Next slide, please.
Okay.
Next slide. As my previous speaker Abhinav, he has already elaborated what is TB, how it is diagnosed, how it is controlled, etc. So I am not going to that. I just want to highlight there are a lot of challenges why it is difficult to achieve elimination by 2025. There are a lot of challenges. There is one of the most important challenges gap in case identification. See, as per data which I was looking at, the estimated TB in 2019, that means before arrival of this COVID pandemic, it was 10 million estimated, but at that time we could this is global I am talking about, we could diagnose 7.1 million. So there was a gap of 2.9 million, and India accounted for 17% of the gap, which amounts to 4,93,000. That means about 5 lakh cases we missed. We could not diagnose. So there are other challenges also that he has already explained. So what we observed that silicosis, as you know, it is an occupational disease. It is primarily an occupational disease, but there are small incidences where without occupation it may happen, which is known as non-occupational disease, non-occupational silicosis or para-occupational silicosis. Now coming to silicosis is, as you have seen this picture, there is a dry drilling and manual cutting. Please go back to the previous slides. Yeah, dry drilling and manual cutting, and it generates a lot of dust. These dust contains silica. Now silica, you know, it has certain characters of metal and certain characters of non-metal. When these workers, they keep on inhaling this silica dust, it produces inflammation in the lung, and ultimately lung is damaged, and normal healthy lung tissue is replaced by abnormal fibrous tissue. Ultimately they develop silicosis. Next slide, please. Next slide. Yeah. On the left side, previous one. On the left hand side, there is a lung, a picture of lung. You see the dust. This kind of dust, it has three different sizes. The downmost, the less than 4 micron. This silica dust containing silica, it reaches up to the level of alveolus. When it is above 4 micron but less than 10 micron, it usually deposits into up to the third generation of bronchus, the second arrow. When it is below 100 micron but above 10 micron, usually it sets into the trachea and the throat, which causes irritation. So we are concerned silicosis is caused by this respirable fraction of the silica dust, which is of sizes of less than 4 micron. So silicosis is a debilitating progressive disease, often fatal at an advanced stage. It is caused by respirable crystalline silica. Now silica particle chemically is of two types. One is the amorphous type, one is crystalline. Amorphous does not cause silicosis, but the crystalline category, it causes silicosis. The global prevalence of silicosis warrants further investigation into methods. Why I am talking, the silicosis is often detected at an advanced stage, because most of the occupational diseases are preventable. These are not curable. It is preventable provided the disease is diagnosed at an early stage. Similarly, silicosis, if it is diagnosed at early stage, it is preventable. But often it is diagnosed at a late stage when it is not curable, and the patient often die at a premature age of 40 to 60, between 40 to 60. And conventionally, silicosis is diagnosed by spirometry, that means lung function test, by X-ray and high-resolution CT scan. These play an important tool for diagnosis of silicosis and respiratory surveillance. But these all, they detect silicosis at an advanced stage, relatively advanced stage. So we need to find out some effective biomarker by which very early detection of silicosis is possible. Next slide. And India has a huge burden of silicosis, and mostly in the informal economy sectors. As per a report published in Lancet in 2019, it was estimated that 11.5 million workers at risk of silicosis because of their day-to-day exposure. Now, we believe this is gross underestimation because nowhere they have explained, they have described the methodology. Unless the methodology is described and it is correctly designed, the estimation, there is a chance, there is a high chance of underestimation. So we believe it is underestimation. I will come later why it is underestimation. Now, another problem is silicosis is the silicotuberculosis, because often the silicotic subjects, they suffer from tuberculosis because we live in an endemic country. India is an endemic country for tuberculosis. Many of us, most of us, or all of us, we we are infected with tuberculosis during our childhood, but we are not diseased. There is a distinct difference between infection and disease. Infections means entry of the organism inside the body. That means there is entry of organism inside our lung, but it remains silent inside the lung. Because of our body immunity, it cannot flare up to cause disease. But when, because of silicosis or any other disease like HIV or like diabetes or like cancer or chronic renal disease, these are the diseases which reduces immunity. And when immunity is reduced, the TB organism which is inside our lung, which was hidden, which was slept for a long time, it flares up. Suddenly, it becomes active. So the silicotic subjects, they suffer from silicotuberculosis often. Other than silicotuberculosis, the silicotic subjects suffer from kidney disease, nephrotoxicity. There is increased chance of stroke, increased chance of autoimmune disease, and lung cancer. So by preventing silicosis, we can prevent so many diseases, including lung cancer and TB, etc. Another thing, there is a lifetime risk of development of pulmonary tuberculosis in silicotic subjects. Why lifetime risk? Because when the person inhales, continuously inhales silica particle, it damages lung macrophages, and lung macrophages are responsible for engulfing external organisms, including TB organisms. Now, what happens when these macrophages tries to engulf the silica particle? Then the cytokine is liberated. Ultimately, the macrophage is destroyed. So there is a continuous destruction of the lung macrophages. So there is a destruction of lung immunity, and because of decline of lung immunity, they suffer from tuberculosis. So in South African study, it has been observed the gold miners, after their retirement from their service, uh, then they stop being exposed. They suffer from, they within a year, 1 year or 2 years, they start suffering from tuberculosis. So there is a lifetime risk of developing pulmonary tuberculosis in silicotic subjects, even after stoppage of silica dust exposure. Actually, what happens when there is TB and silicosis? Three things happen. One is there is a difficulty in detection of tuberculosis in silicotic subjects. Second is there is an uncertainty of treatment outcome. Means normally, as my previous speaker has told, the normally TB is treated by 6 months regime, but when there is underlying silicosis, the treatment has to be extended for longer time because there is a uncertainty of reaching the correct amount of drug into the correct spot. And third one is that there is a higher chance of drug resistance when there is underlying silicosis. So for this reason, the diagnosis of silicosis is very important for control of tuberculosis. Next slide, please. We conducted one study along with ICMR Jalma Institute in Agra, and there we took 205 glass factory workers in Agra. There is a near Agra, there is one district, Firozabad, and there is a huge industry of glass bangles. They produce glass bangles. So in this glass means it is glass contains high amount of silica. So those people who work in the glass industries, many of them, they inhale this glass dust, fine glass powder dust, and ultimately they develop silicosis. Now in Firozabad district, we screened 205 glass factory workers, and we found 46% of them, they suffered from pulmonary tuberculosis, whereas non-glass factory workers, only 4% they suffered from pulmonary tuberculosis. Next slide, please. Among glass factory workers, we, based on chest X-ray, we detected those who are silicotic and those who are not silicotic. Among silicotic, 114 silicotic subjects, of them the TB detection rate was 66.6%, but those who are not silicotic, X-ray based, TB detection rate was 20%. This again proves, and the odds ratio is 7.57. That means those who are having silicosis, they are 7.57. That means almost 8 times they are more at risk of developing tuberculosis. Next slide. So it appears unless silicosis is controlled, TB will not be controlled and eliminated in India, as burden of silicosis appears to be high and grossly underestimated. Silicosis is usually diagnosed at an advanced stage. Nothing much can be done to prolong victims' life or preventing premature deaths if detected at a late stage. Now, secondary prevention of early detection of secondary prevention. What is secondary prevention? Primary prevention means if we try to prevent before occurrence of the disease, it is known as primary prevention. Once the disease has occurred, that means after exposure, if we try to prevent, this is as known as secondary prevention. So, as we are trying to identify silicosis at very early stage, that I am coming later, we have identified or explored one biomarker, which is a lung protein known as club cell protein 16, or club cell protein 16. In short, it is known as CC16, which is secreted by the epithelial cells of terminal bronchiole. Now, what happens? We have a certain level of this CC16. It is secreted by the lung cells, club cells, and ultimately it dissolves into the systemic blood circulation. And by taking one drop of blood by pricking finger, if we estimate this CC16, by estimating CC16 value, we understand how much lung is damaged. Because in silicosis, there is a progressive damage of the lungs. So there is a progressive decline of serum CC16 value. So by monitoring serum CC16 level, along with the history of occupational silica dust exposure, we can monitor, we can detect early, and we can monitor the progress of the disease. If we serially try to identify, or we periodically we screen them, we can identify. So by doing detection, by early detection of silicosis, by checking the serum CC16 value, once it is diagnosed that he is suffering from silicosis, then if we screen them with CBNAT or TrueNAT, their sputum, we can identify silicotuberculosis at very early stage. Anyway, next slide. We conducted one study in our institute, that National Institute of Occupational Health, and there initially we found that higher the duration, higher the duration of exposure, silica dust exposure, lesser is the CC16 value. So based on that, we conducted another study. In that study, next slide please. In that study, next slide. In that study, based on chest X-ray, we tried to approximately quantify the lung damage, and we took. I am telling. Okay, go to next slide. Next slide. This is a typical X-ray of silicosis. You see there is a bilateral patchy small white opacities, just sago grain. These are the small dots due to silicosis. This is a typical slide, X-ray slides of silicosis. So how did we quantify the silicotic chest X-ray? We calculated, we gave some logical lung damage scoring system to the size and shape of these small opacities. We gave logical scoring values to the large opacities, because when the small opacities coalesce, they produce large opacities. And based on the profusion, means the density of these small opacities, we gave certain logical values. In this way, we categorize the lung damage, silicotic lung damage, into early lung damage, intermediate, moderate lung damage, and the severe lung damage. Next slide, please. Next. Anyway, okay. In this slide, you see on the left hand side, the 16.3 nanogram per milliliter is the CC16 value. These are the healthy people. They are not exposed to silica dust. But the second one from the left side, you see the lung damage scoring was 3.3, means it is a early silicosis. The CC16 value is 8.4 nanogram. The next one is the lung damage score is 9.9. That means intermediate silicosis, moderate silicosis. The CC16 value is 4 nanogram per milliliter. And when lung damage is very high or severe silicosis, the CC16 value is 0.7 nanogram per milliliter. Next slide. In this slide, you see there is a continuous decline of the CC16 value as per lung damage. As per lung damage scenario. So, next slide. Therefore, CC16 may be, this was our conclusion, CC16 may be used as a possible cost-effective proxy biomarker. Why we are calling it proxy biomarker? Because CC16 is not specific to silicosis, but CC16 will indicate, reasonably well indicate about the silicotic lung damage if it is applied to a group of occupational silica dust exposed people. So that's why it is known as the proxy biomarker, proxy marker. If we follow up a group of silica dust exposed workers periodically, it will indicate early stage silicosis reasonably well, which may be confirmed by chest X-ray or high resolution CT scan for required intervention. Now, only confounder is a smoking. If the person is a current smoker, smoking also damages mucous membrane or the inner layer of the bronchioles, the bronchial tubes. So, which can be adjusted. Our suggestion is stop before asking for CC16 evaluation. Ask him to stop smoking for 1 month before the date of testing, or add 2 nanogram over CC16 test result when it is a heavy smoker, or 1 nanogram for moderate smoking. Moderate means 5 to 10 cigarettes per day, or heavy smoking means more than 10 cigarettes per day. Next slide. Next. So following identification of that biomarker, ourselves and our sister institute, National Institute of Virology, they have their one unit in Mumbai. We have our 3 colleagues, they are biotechnologists. They developed, we explained this is our requirement, and they developed this kit using immunochromatographic assay technique, lateral flow immunochromatographic assay technique. On the upper left hand side, you see there is one red line, that is a control line. Unless that line appears, the test will be considered as invalid. You see there is a small depressed part where the 1 drop of serum to be put, and it will flow through the tunnel, and ultimately it will produce lines. On the serial number 2, you see there is, apart from the negative line, that control line, there is another one band. One band indicates 0 to 6 nanogram. That means moderate to high or advanced silicosis. On the lower left side, you see, other than control line, there are 2 red lines. 2 red line means the CC16 value is 6.1 to 9 nanogram. This means early X-ray detectable silicosis. And on the right lower image, you see the serial number 4. Other than the control line, there are 3 more lines. That means either CC16 value more than 9 nanogram, either the person is very early stage of silicosis, which is not detectable by chest X-ray, or he is a healthy subject. I am coming to it later on. Next slide. So our conclusion is the serum CC16 may be used as a proxy marker among workers with history of occupational silica dust exposed workers for early detection of silicosis through periodic screening using CC16 detection kit. All primary health center workers need to be trained towards this to support these activities. All vulnerable informal economy sector workers must undergo annual screening for his CC16 status through nearby primary health centers. Suspected cases need to be confirmed by chest X-ray or high-resolution CT scan. This may be linked with some unique identifier like Aadhaar, because CC16 is a dynamic. It is in relation to time, it will change. So, and we have many migrant workers. Suppose this year somebody will work in Punjab, next month or next year he will go to Haryana. So our suggestion is once in a year, at least once in a year, if not more, he should be screened in all the nearby primary health centers or some suitable centers, CC16 value, to track the progress of the disease. All vulnerable formal economy sector workers, including hired and contractual workers, must undergo serum CC16 evaluation annually and to be linked with unique identifier. A suitable legislation is required. Now the problem is silicosis is an occupational disease. It does not come under health, uh, although it is a disease, but these workers are primarily under Ministry of Labor, Ministry of Mines, Ministry of Industries, etc. So there is a suitable legislation is required in coordination with all the relevant departments like Department of Health, Department of Labor, Department of Mines, Department of Industries. All should work together, holding hands each other's. Then only control of silicosis will be possible. And unless control of silicosis is not possible, control of tuberculosis is not possible. And we suggest the National Tuberculosis Control Program, now it is Elimination program, should be linked with National Silicosis Control Program, which should be initiated immediately, not only for the sake of not only for the sake of silicosis control, but also for the sake of TB control. So a national silicosis control program is urgently needed for control of both silicosis and tuberculosis. They should be integrated. Silicosis control program must be integrated with national tuberculosis elimination program. Next slide. Next. Next. Am I audible? Next.
So, hello everyone. So, joining from in-house research team is Shaurya Singh. She has rich experience in management consulting, and she has been an integral part of the healthcare team. So, over to you, Shaurya.
Hi everyone. Himanshu, I would like that you change the slide so that I can start with it. Yeah. So basically, like a lot of things have been highlighted by the former speakers. So I would not take much time and I would highlight few things that I would like to present in front of you. First of all, the statistics related to TB. We all know that TB is contagious, TB is harmful, but do we all know that what exactly the statistics are and what are the numbers? So basically, every year, like these statistics that I am presenting are from WHO. So, a total of 1.6 million people died from tuberculosis in 2021. And tuberculosis is the 13th leading cause of death and second leading infectious killer after COVID 19. In 2021, the 30 high TB burden countries accounted for 87% of the new TB cases. So, as we can see the stats, the number of TB patients and the prevalence of TB is increasing. So, what we are doing, like what we are, the main focus for having this discussion was that what we are doing, what exactly is the scenario related to tuberculosis, what are its symptoms, causes, and in particular, like we know that India is having a high prevalence rate of tuberculosis, and there are a lot of cases which are diagnosed and a lot of going undiagnosed. So today we'll be discussing that. Can we move to the next slide, please, Himanshu? Yeah. So, like my former speakers have already highlighted different tuberculosis control programs that are being organized by the government of India. So, yeah. So, this is National Tuberculosis Control Program, which was launched by the government of India to eliminate the tuberculosis from the country by 2023. And later on, it was revised and it came out as revised National Tuberculosis Control Program, which focuses on eliminating tuberculosis from India by 2025. Himanshu, can we move to the next slide? Yeah, next. So basically, I did not highlight much on that because the former speakers have already explained us the National Tuberculosis Control Program as well. So what we did, like we were, if I talk about the market scenario, so what we were doing since last few days, we were having few polls and surveys that we were running. And firstly, we conducted a survey on that what is the most common method for diagnosing tuberculosis according to the different people, like how much people are aware about the different diagnostic tests. So as we all know that these are the results of the test, and it came out that blood test holds the largest share in terms of all the different tests like lymph nodes or skin test, imaging test, and sputum test. As these survey results are from the people, like what people are thinking about different diagnostic methods for tuberculosis. Manshu, can we move? Yeah. Next is like we also had a poll on, like, what are the common methods for diagnosing treatment of tuberculosis. So tuberculosis, we all know that there are first line therapy and there is second line therapy, and both are majorly comprising of antibiotics. So this was like we ran a poll and we got these results, and according to which these are the prominent drugs that the user feels for the treatment of tuberculosis. Next, please. Now, this is a very open ended question that will India succeed in eliminating tuberculosis by 2025? So, these are the poll results that we have got from our respondents. Like Dr. Kamlesh highlighted that if we succeed in eliminating silicosis, then surely we would be able to eliminate tuberculosis by 2025. And as Abhinav also illustrated different government policies and what all the initiatives different governments are taking, so, based on that, we would be able to eliminate tuberculosis by 2025. And this is what our survey results also say, that yes, we can eliminate tuberculosis by 2025 if we take, all the we take all the things into consideration, like early diagnosis, prevention, awareness, all those things. So surely we can eliminate tuberculosis by 2025. Next. So basically, why I was emphasizing that why we can, eliminate tuberculosis by 2025, because first thing, like the government is taking its initiatives itself. Secondly, like Dr. Kamlesh emphasized on silicosis part. Thirdly, there are, various new techniques that are emerging, like immunotherapy, cell therapy, gene therapy, which are not only useful in treating different chronic diseases like cancer, but yeah, they can be treating tuberculosis as well. There are several studies, lot of studies that are going on worldwide. Like I can tell you that there are around 1095 clinical trials that are going on worldwide related to identifying a potential treatment for tuberculosis. And in India also there are around 76 studies that are going on till 23rd of March 2023, and they are in different phases for identifying a new potential treatment for tuberculosis. Similarly, there are studies that are going on related to immunotherapy, cell therapy, and gene therapies, which can become the future for the treatment of tuberculosis. For instance, I would like to highlight, like in immunotherapy, there is interferon gamma, which has been identified to be useful in the treatment of tuberculosis. Himanshu, can we move forward? There are cell therapies as well. So basically, cell therapy involves the use of the cells. These can be from your own body or from a donor, which can be used to treat different diseases and target different pathogens. So yeah, so different stem cells are being used for targeting tuberculosis. Studies are going on worldwide. There is a T cell therapy also that is going on, which is known as TB adoptive T cell therapy, on which a lot of research has been done earlier also, and right now also it is being it is in its phases of development, and maybe in the future we can have T cell therapy and cell therapies for the treatment of tuberculosis. Next slide, please. Next is tuberculosis through gene therapy. So basically, gene therapy is the modification of the person's own gene or genetic makeup for treating or preventing a particular diseases. And it has been identified that we can use gene therapy for the treatment of tuberculosis only. Recently, there is a one type of gene therapy that is being discussed, that is being under study and under discussion is going on for the treatment of TB by delivering the drug of antimicrobial peptide or proteins, so that by changing the genetic makeup, TB can be targeted, and basically this will focus on killing the mycobacterium tuberculosis bacteria. So similarly, a lot of studies worldwide are going on. Himanshu, next slide, please. So, as I stated earlier, also regarding the clinical trials that are going worldwide, like I stated earlier, that there are around 1095 trials, and of which 76 are going on in India and are in different phases of development. Next, please. So, yeah, any questions?
Okay. So, hi. Yes, we do have received some questions for both of you. One question is that is it possible that TB affects only the lungs, or there are other body parts also that it has equally impact on? And what is the scale of the same? Abhinav sir, will you answer this?
Uh, yeah, sure. Uh, Actually, TB, we inhale the bacteria.
Okay.
So the TB directly goes into lungs, and from the lungs it can go anywhere, anywhere on the other parts of the body. But the frequency is that pulmonary tuberculosis is much more than extrapulmonary tuberculosis.
Okay. Sure, sir. And another question that we have over here is that these days we are facing number of issues related to cold, cough, and fever problems, and how to differentiate it with the COVID and TB.
Uh, we can we can differentiate. We can normally not differentiate between them because it has similar symptoms, very similar symptoms in COVID and as well as in tuberculosis, or it may have no हो सकता है ये TB भी ना हो, COVID भी ना हो, normal cough या cold हो. So better is that if we are having cough for more than 2 weeks, we can go for the testing. And if we can go for both testing. We can go for the RT-PCR or we can go for the sputum test.
Hmm.
We can get the result from that. We cannot easily differentiate between the normal cough or it is COVID or tuberculosis cough.
Okay. Shaurya, you just mentioned about the new studies related to that. Is there any study right now going on or in progress or in some phases which helps us to differentiate between, or is there a new biomarker which help us to understand that this fever is because of the COVID and this is resulting out of tuberculosis?
Yeah, so as you asked me, the studies are good. The studies are going on, but there is no study that which has a particular result and it is out that that this particular biomarker is being used for differentiating. So there are studies that are going on, but there is no potential biomarker outside right now.
Okay, okay. So another question that we have for you, Shaurya, is ki what are other medical problems that can elevate the risk of the tuberculosis.
Okay, so like as we have mentioned earlier, that there are different diseases, that can lead towards tuberculosis, like any chronic conditions also that we are suffering from, or any kind of, untreated cold or cough that can contribute towards tuberculosis.
Okay. So, Abhinav, sir, would you care to add more diseases in the list that because of that the risk for TB increases?
In tuberculosis, we go for basically we focus on the diabetes or HIV because
Okay,
these are so इससे इम्यून सिस्टम बहुत ही कमजोर हो जाता है
right, sir.
और हमें इम्पैक्ट पड़ता है कि ये ट्यूबरकुलोसिस के चांसेस बहुत ही ज्यादा होते हैं ड्यूरिंग द दिस HIV, स्पेशली HIV.
Okay. So, like you just mentioned about the HIV and in your presentation also about the resistance thing. So, we have a similar question for
Yeah.
you all. What if the drug which is used for the treatment of the TB does not work? How we treat the disease, which is a typical case of the resistance against the bacteria. How do we deal with that in the current medical scenario?
Can you repeat the question? I didn't get.
What if a person develops, sure, sir. What if the person develops a resistance against the tuberculosis medicine or drug? What is the next line of treatment for that?
इफ अ पर्सन अगर किसी पर्सन को ड्रग रेजिस्टेंस हो भी जाता है तो हम उसे MDR या XDR में ट्रीट करते हैं फॉर दैट फॉर डायग्नोसिंग द ड्रग रेजिस्टेंट वी गो फॉर द NAT. That is,
Okay,
we check on the CB NAT whether the patient is drug resistant or not. After that, we send that sample for the culture and see that what are the drugs that the patient is resistant to.
okay, sir.
Then we plan according to that which drug is resistant, which drug is not resistant. Then we plan the uh, treatment according to that, the results of the culture.
Okay, sir. So, based on your interaction with the patients and like you are working on the war foot with the patients of the tuberculosis, is there a particular kind of age group that is more prone to the tuberculosis?
Uh, More prone age group is between 40 to 60. We get more patient in that age group, and we have pediatric patients also. Uh, but the main focus age group is 40 to 60 is the main age group that we have.
Okay. Uh, well, that's all from our end. We have received these many questions. Again, thank you, sir, so much for joining us. And
Thank
through
you.
our discussion and presentation, we have gained valuable insights into the challenges and the opportunity that are presented to us in the fight against the tuberculosis. We have heard from the experts in the field who are working tirelessly to develop new solutions and push for better treatment. Again, to all the viewers right there, thank you once again for contributing to this event. I hope that you found that today's discussion was informative and engaging, and we are looking forward to continuing this dialogue in the future. Thank you and have a good day.
Thank you.
Thank you.
Broadcast, and broadcast, and broadcast, and broadcast.